All right. I want to welcome commissioners and members of the public. This is uh, perhaps our last remote-only commission meeting, yet to be determined, but hopefully in the future we will transition these meetings to hybrid. I think we've learned a lot about remote meetings, that there is some value. There's tremendous value for those of our commissioners who have a long distance to travel, and I'm grateful that they're able to participate much more often. But given that this is a remote-only meeting, additional ground rules will apply. I'll begin with a roll call. During the meeting, I'll ask the people speaking identify themselves before speaking. That way, commissioners and members of the public will know who's speaking, just as if we were together on Reisterstown Road and Patterson Avenue. We're using Zoom meeting today. All commissioners may speak. The public and most staff should self-mute and may not speak unless recognized by the chair. Due to the possibility of background noise, I ask that commissioners and others please mute your phones when you're not speaking. Please pay attention to that. For this meeting and at all future meetings, we'll post documents that will be acted on or discussed at least a day in advance so that members of the public will have time to download them before the meeting begins. We'll continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the Commission's website and our various social media channels. I will now call the roll. Commissioner Akintade.
Present.
Commissioner Bandari. I've not seen him yet today. I don't believe he's here. Commissioner Boyer. Not seen her either. Commissioner Boyle.
Here.
Commissioner Brumbutt.
Here.
Commissioner Dorden.
Here.
Commissioner McCarthy. I don't believe so. Commissioner Metz. Commissioner O'Connor, I saw you.
Here.
Commissioner O'Grady. Is Dr. O'Grady joining us, do we know? Commissioner Reimer. Commissioner Sargent, I saw you.
Here.
Commissioner Thomas.
Present.
And Commissioner Wang.
Marcus Wang, present.
Excellent. And I believe we have, by a thin margin, a quorum. If anybody needs to drop off, if they could please send a note in the chat so that we will know if we run into a problem with a quorum today. We have many action items on the agenda. Any other commissioners who didn't respond joined the call since I began the roll? Hearing none. Included in your packets are copies of the minutes from the May 20 public meeting of the commission that took place by video conference. I'll entertain a motion to approve those minutes.
So moved. O'Connor.
Do I have a second?
Commissioner Thomas, second.
I have a motion and a second. All in favor?
Aye.
Aye.
Any opposed? Excellent. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Okay. Does the executive director have any updates? Ben? Perhaps that's what's been going on with my phone clicking for the past couple minutes. While I look at this, Paul Parker, do you have a, no, that's not Ben. Paul, do you have a new employee to introduce?
Yes, I do. Can everyone hear me?
Yes, we can.
Okay. Again, I'm Paul Parker, Director of the Center for Healthcare Facilities Planning and Development, and two updates. This will be the last meeting today of our Chief of Certificate of Need, Kevin McDonald. Kevin is retiring, and his last day will actually be tomorrow. Kevin has been our chief leading our CON analyst in fulfilling our regulatory responsibilities in the area of certificate of need. And he has served us for almost 8 years. And he's been a great asset for the Maryland Healthcare Commission. He came in at a time when we were just beginning, unfortunately, a pretty heavy round of major project reviews kind of during the period of 2014 through 2017. And he met that challenge. He came to us from a career primarily working in hospitals in planning and development, and just wanted to thank him for his dedicated service. It's a cliche at times like this to say that he was one of those people who was the last person in the office every day, turning out the lights. In this case, it's actually true. Kevin was a very hard worker, which was something that this job requires to just kind of keep up with the level of production needed. So I wanted to thank Kevin and recognize him here. I'm hopeful that he can show up on a screen if possible.
So I too want to offer Kevin my gratitude. The tremendous amount of work was very obvious to all of us. A tremendous contributor and a fantastic resource of institutional knowledge that is going to be tremendously missed. I'm not sure. We somehow seem to, all institutions seem to be able to move on when those of us who've been around a while leave. But we're certainly going to miss Kevin and miss his tremendous contributions.
Okay. And I'm sorry Kevin hasn't shown up. Somewhere in the same room with our executive director, perhaps. I'll move on though. I'm very pleased to announce that we have a new chief for CON replacing Kevin, and she is Winnie Hawk, who is coming to us with a long career in both government and the private sector. Winnie's coming to us directly from the Board of Physicians, which is just across the street and down the block, and she has served for about 10 years there as their manager for policy and legislation. Before that, she did a short stint at the Maryland Department of Health, which was the Department of Health and Mental Hygiene back then, as the director of the Office of Government Relations for the department. And before that, she actually had a short stint doing a similar job with Baltimore County government. And before that, so now we're going back to the end of the 20th century. She had a few years working at the Greater Baltimore Medical Center. So she has a variety of experience, public sector and private sector. She is going to be a great addition to our staff. So just wanted to welcome her to the commission.
Welcome.
And like Kevin, I was hoping she could show up. Doesn't look like she is, but.
Well, I just talked to Ben, and apparently there are some technical challenges in the office right now. So if any of those people are in the office, that would sort of explain it.
Yeah.
Okay, the conference room is now online. You should see that picture now.
Great. Ben, are you there? Hello, I can see the picture, but I can't hear Ben yet.
Guys.
Now we can hear you.
Okay.
All right, great. So thank you, Kevin, and welcome, Winnie, and we look forward to hearing more. Kevin, we said a bunch of very flattering things about you while you were not on the Zoom, but thank you very much for fantastic amount of service to the citizens of the state of Maryland. Ben, you want to go ahead with your update?
Yes, thank you very much. This is our first conference room based quasi semi face-to-face meeting. We intend to go to the next level in July where it will be optional for commissioners to attend in person. As an incentive, I can promise a nice boxed lunch. We haven't figured out where you'll eat that. It may be out on the street, but we will provide some more information on that. Seriously, though, I wanted to be sure that we kept my update to as short as possible. The big noteworthy event is, of course, on Tuesday, the governor announced the end of the state of emergency. Some of the orders will end on July 1st. Most of the executive orders and those that pertain to the Healthcare Commission, those that were the basis for our actions, will actually end on August 15th. We've concluded that we can begin to, number one, reconsider the 40 or so emergency CONs that were issued from March through January of 2021. These emergency CONs were approved on the basis that they would continue through 30 days after the end of the governor's state of emergency, which would mean they would continue through September 15th. The commission does have the ability to extend them for good cause shown by the applicant. Although we took the emergency CON decisions largely on our own authority, before we issue new guidance on the conversion of emergency CONs to permanent CONs, or the standing down of that capacity, the chair and I will be meeting with HSCRC and the secretary and others that are involved in planning for the healthcare delivery of healthcare services in the state, to look at how we balance the standing down of this authority with the ongoing need to maintain some surge capacity through the next several years, as clearly the pandemic, the COVID-19 virus is in retreat, but it is not fully defeated until we have greater numbers of the population vaccinated. It's going to remain a challenge. So stay tuned on that. We will be issuing guidance, but at this point have not provided any information to health systems on additional direction on converting the CONs. In addition, on March 31st, 2020, we issued orders to health systems that maintain cardiac surgery and percutaneous coronary intervention programs regarding the reporting of data to the commission and regarding certain standards that are in place in our regulations. We waived that for the duration of the public health emergency. We expect to be issuing guidance on that over the next 30 days on the resumption of those requirements and the reestablishment of the standards. That concludes my formal update. I know that we were somewhat disjointed today, and I did also want to recognize Kevin's final commission meeting. He joined in, I didn't realize this, late 2013. And over those 9 years, he's really been a foundational part of almost every single CON review, and certainly all the critical CON reviews that occurred over those 9-year periods. If I think of the ones that were most controversial, including the relocation of Washington Adventist to White Oak, he was there. The relocation of Prince George's Hospital Center to the recently opened Capital Region Medical Center in Largo, he was there. The review and controversial award of a cardiac surgery program to Luminous Health, he led that review. And certainly there are other areas where they probably did not garner as much attention, but were significant because they represented the commission taking a first step in employing its planning capabilities. They include the resumption of review of hospice programs, the energetic effort to establish alcohol treatment programs in the state. I think I count more than a dozen programs that were established under Kevin's guidance. Many commissioners were fortunate to work with Kevin, probably the commission staff person who had more interaction with commissioners than anyone else. And I think all of you found him knowledgeable, patient, and well prepared. And certainly all key requirements for a commission staff member who deals directly with busy commissioners who take it upon themselves to become reviewers. And I never heard word one with dissatisfaction on his performance. He also is leaving us today with a staff that is better positioned to carry forward. And Kevin spent considerable time figuring out approaches to bring our staff up to speed as they joined us in what I think is one of the most difficult jobs here at the commission, certainly one of the most challenging for junior and mid-level staff is to face down oftentimes very skilled legal counsel from health systems, expert health planners from health systems. And with Kevin's guidance, our staff holds its own. A lot of Kevin's high and strong qualities I attribute to his several years in the Midwest. But I can't really be sure that that's the case, but I do know that he did bring many good qualities, strong qualities to the commission. They will be missed, but we understand and wish him all the best in the years going forward. So thank you, Kevin.
Thank you, Ben. I remember Iowa City very well, and enjoyed my time out there, although, you know, Iowa seems a different place now than it was then. It's been a privilege to work with all of you here. Time has gone by in really a whirlwind. I guess as you get older, each year goes a little quicker. And as I think back, the privilege of working at the Maryland Healthcare Commission and coming to Maryland sort of took me my career full circle in a way. My first job after leaving Iowa City, graduate program, was at the South Carolina Appalachian Health Council in Greenville, South Carolina, where I did planning and CON review work before being recruited into hospital and health system work for probably the next 25 years. And now I have the opportunity to come back into the public sector, and you know, I've always believed in public service, and it's been a privilege to work with the commission. I've been very impressed with the time the commissioners give, their level of engagement, and the very stimulating discussion that happens here. And I'm very glad to have had the privilege to be here.
Thank you.
Thank you, Kevin.
Thank you very much.
Good luck in the future.
Thank you.
Moving on in our agenda, agenda item number 3, certificate of ongoing performance for percutaneous coronary intervention services for UPMC Western Maryland. The next agenda item is for consideration of 2 applications that each seek a certificate of ongoing performance for PCI services. The applicants are UPMC Western Maryland and Meritus Medical Center, each of which has both primary and elective PCI services. Staff will discuss the state health plan standards that apply in each of the applications, and then there'll be a separate brief discussion and vote on each application. Jessica Raisinen, Program Manager, will present the staff's report and recommendation on this application. Jessica, please proceed.
Good afternoon, commissioners. Can everyone hear me all right?
Yes, we can.
Great. So as we've discussed at previous meetings, statutory changes enacted in 2012 require the commission to periodically certify that cardiac surgery and percutaneous coronary intervention programs meet performance standards established in regulations. A summary of PCI service performance standards that have been established by the commission is shown here. Standards relate to data collection, institutional resources, quality, patient outcome measures, physician resources, volume, and patient selection. We'll move on to the next slide where we'll discuss University of Pittsburgh Medical Center, Western Maryland's compliance with the standards. Okay, there we go. So UPMC Western Maryland was previously known as Western Maryland Health System, and they have both primary and elective PCI services. UPMC Western Maryland is a general hospital in Allegheny County that has cardiac surgery program on site. As shown on the slide, UPMC Western Maryland is meeting the requirement that primary PCI services be available 24 hours a day, 7 days a week. Over rolling 8-quarter periods, UPMC Western Maryland complied with the door-to-balloon standard in all periods between 91.5% and 96.4% of non-transfer primary PCI cases had a door-to-balloon of 90 minutes or less in each rolling 8-quarter period between January 2015 and December 2019. The volume of PCI cases has ranged from 287 to 349 cases annually between 2015 and 2019, greater than the target volume of 200 cases. And the primary PCI volume ranged from 43 to 61 cases annually between 2015 and 2019, which is greater than the 36 cases that are required for rural programs. PCI programs are also required to hold monthly multiple care area group meetings to discuss potential improvement to the process of identifying and treating STEMI cases. While meetings were not held on a monthly basis during most of the review period, UPMC Western Maryland reported that meetings were held monthly from October 2020 through April 2021. MHCC staff recommends that the commission find that UPMC Western Maryland meets this standard, but that a condition be added to the certificate of ongoing performance that requires the hospital to make semi-annual submissions to MHCC staff, documenting meeting dates and attendance for each meeting. Next slide. PCI programs are required to hold interventional case review meetings at least every other month. UPMC Western Maryland held 2 to 4 peer review committee meetings annually from January 2015 to December 2019. Additional case review infrequently occurred at other committee meetings, such as their CAF PCI meetings. However, the hospital is willing to commit to performing interventional case review at meetings at least every other month in the future, documenting that case review occurred and tracking attendance at each meeting. UPMC Western Maryland states that this practice was implemented starting in October of 2020. Staff recommends that the commission find that UPMC Western Maryland complies with this standard and recommends a condition be added to the certificate of ongoing performance, requiring semi-annual submission to MHCC staff of documentation of attendance and that meetings are held at least every other month. Between 8% and 10.7% of elective cases were reviewed externally semi-annually each calendar year, exceeding the 5% required. At least 6 cases per interventionalist were reviewed externally per year, unless an interventionalist did not perform 6 cases. However, one locum interventionalist had cases from 2017 to 2019 reviewed later because they were not initially included in the regular semi-annual review. MHCC staff recommends that the commission find that UPMC Western Maryland complies with this standard. UPMC Western Maryland indicates that the standard for evaluation of individual interventionists was met as well. In addition to the external review that I just described, all cases of PCI were reviewed internally from January 2015 to December 2019 as well. Next slide. So no primary UPMC Western Maryland performed similar to the national benchmark for STEMI and non-STEMI cases for the 12-month periods that ended in December 2019, March 2020, June 2020, and September 2020. Prior to that, UPMC also performed similarly to the national benchmarks, but the standard didn't apply until that first reporting period, December 2019. No primary PCI cases were identified as inappropriate during the review period, and no cases were rarely appropriate with respect to ACC or AHA appropriateness criteria. External reviews raised very few concerns about clinical appropriateness or angiographic appropriateness as well. Staff recommends that the commission find the hospital has complied with all standards and approve a certificate of ongoing performance to allow UPMC Western Maryland to continue providing primary and elective PCI services for 4 years with conditions that are found on page 24 of your staff report. The first condition, to summarize, states that UPMC Western Maryland shall hold meetings at least every other month for the purpose of conducting interventional case review and to submit the attendance list for each of these meetings until at least February 1st, 2022 on a semi-annual basis. After this date, the executive director may release UPMC Western Maryland from the reporting requirement if it's determined that the hospital has achieved substantial compliance with this condition. The second condition is that UPMC Western Maryland shall hold monthly multiple care area group meetings and submit attendance lists for each of those meetings semi-annually until at least February 1st, 2022. After that date, the executive director may release UPMC Western Maryland from the reporting requirement if it's determined that the hospital has achieved substantial compliance with the condition. We have several hospital representatives on the line. We have Tim Abril, the Director of Perioperative Services and Interventional Imaging, Dr. Christopher Haas, the Medical Director of Cardiology, Jamie Carstetter, the Chief Nursing Officer, and Chrissy Lechlitter, the Director of Nursing. They can respond to any questions that I cannot answer or provide additional information on the program as needed.
Thank you, Jessica. Do I have a motion to approve the application for the UPMC Western Maryland Certificate of Ongoing Performance with conditions as listed by Jessica?
Commissioner Thomas, so moved.
Second, Commissioner O'Connor.
I have a motion and a second. Do I have questions? Discussion.
In the report that was just given, you have outcomes, you have demographics of that patient population?
So we do not provide those in the report. We have data that's reported to us on a regular basis from all of the programs. So that data analysis could be done, but for these specific ongoing performance staff reports, we have not been looking by demographics specifically. I will say that the adjusted mortality rates are already controlled. So those are given to us by the ACC, and they control for several factors to make sure that we're not comparing apples to oranges.
This is the exact same review process that we've used for all of the other dozen or so certificates of ongoing performance
Yes.
that we've done in the past.
Thank you.
All righty. If there's no other questions or discussion, we have a motion and a second. All in favor?
Aye.
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 Any opposed? Congratulations, you have your certificate of ongoing performance to Western Maryland. Next up,
If I could interrupt for just a second I want to confirm that Commissioner Reimer is here in the room with us. So if we add that she is in attendance. For everyone's knowledge.
thank you. I didn't even know the door was unlocked. There was an option to show up.
Okay.
When she heard about the box lunches, she messed
Yeah,
with it.
exactly.
All right. Next up will be the review for Meritus Medical Center. And that will be presented by Marianne Dogo Isanagi, Program Manager. Marianne, please proceed.
Thank you, Mr. Chairman. Good afternoon, Commissioners. Can everyone hear me clearly?
Yes.
Thank you. So Meritus Medical Center is a general hospital located in Hagerstown, Maryland. Currently, Meritus provides both primary and elective PCI services and does not have cardiac surgery on site. As shown on the slide, the hospital has met the requirement that primary PCI services be available 24 hours per day, 7 days per week during the review period between January 2015 through June 2020. With respect to the door-to-balloon time standard, the hospital complied with the standard on a rolling 8-quarter basis between January 2015 and December 2019, with between 79% and 93% of PCI cases achieving a door-to-balloon time of 90 minutes or less. The program also performed over the target volume of 200 cases annually. Program volume ranged from 280 to 308 cases annually between fiscal years 2015 and 2019. The hospital has also performed well over the minimum number of primary PCI cases required. The volume of primary PCI cases ranged from 79 to 102 cases annually for calendar years 2015 through 2019, greater than the 49 cases required annually. The last standard on the slide pertains to a requirement that each physician who performs primary PCI procedures shall complete a minimum of 50 PCI procedures annually, averaged over a 24-month period. The reported physician volumes for the interventionalist who performed primary PCI show that each interventionalist performed at least 50 PCI procedures annually on average over the 24-month periods between 2015 and 2019. Next slide, please. The first standard on the slide pertains to a requirement that a hospital hold interventional case review meetings at least every other month that includes physicians, nurses, and technicians who care for primary PCI patients. We learned that nurses and technologists are now required to participate in the formal interventional case review meetings. However, in 2015, the hospital established an ad hoc forum for case review that includes technologists and nurses that meets as needed. Because case review meetings with nurses and technologists occurred infrequently between 2015 and 2019, we are recommending that a condition be included on the Certificate of Ongoing Performance for the hospital with formal follow-up by the Commission. Next. The hospital, I'm sorry, can you go back? I was not finished with that slide. Thank you. The hospital met the requirement for external review of PCI cases and exceeded the minimum percentage of cases that needed to be reviewed, which is 5%. Between 12.2% and 16.9% of PCI cases were reviewed semi-annually between January 2016 through December 2019. At least 6 cases per interventionalist were reviewed externally per year. Additional cases were reviewed internally to meet the individual interventionalist review standard. Next slide, please. For risk-adjusted mortality rates for the rolling 12-month periods ending in December 2019, March 2020, June 2020, and September 2020, the hospital is performing similar to the national benchmark for STEMI cases. The hospital also met that benchmark for all earlier reporting periods going back to calendar year 2015, but the standard only became effective January 2019. The program only performed primary PCI on suitable patients, and there were no primary PCI cases identified as inappropriate through internal and external review during the review period. And lastly, 1 elective case was identified as rarely appropriate through external case review with respect to 1 or more of the following criteria: clinical criteria and geographic criteria, or the ACC/AHA appropriateness criteria. The hospital provided information about the follow-up on this case, and MHCC staff determined that the response was appropriate. Staff recommends that the Commission find that the hospital has complied with all standards and approve a Certificate of Ongoing Performance to allow Meritus Medical Center to continue providing primary and elective PCI services for 4 years, with the condition that Meritus Medical Center shall hold meetings at least every other month for the purpose of conducting interventional case review that include physicians, technologists, and nurses who care for primary PCI patients as required in COMAR, and shall submit to the commission staff attendance lists for each of these hospital staff meetings held between January and June by August 1st of each year, and attendance lists for meetings held between July and December by February 1st of each year until at least February 1st of 2022. After this date, the executive director may release Meritus Medical Center from the reporting requirement if the executive director concludes that the hospital has achieved substantial compliance with this condition. We have several hospital representatives on the line. Angie Frankhart, Service Line Administrative Director of Surgery, Julie L. Miller, Director, OR Clinical Operations, Jim Ricabo, Clinical Analytics Manager, Dr. Robert Marshall, Cath Lab Medical Director of Cardio Care, Tara Baker, Cath Lab Nurse Practitioner, Cardio Care, Alex Sloan, Cath Lab RN, Betty Myers, Cath Lab Clinical Data Coordinator, and Melver Meminger, Cath Lab Clinical Data Coordinator. They're all on the line, and they can all respond to questions or provide additional information on the PCI program as needed. Thank you.
Thank you, Mary Ann. Do I have a motion to approve the application of the Meritus Medical Center?
So moved.
Commissioner Boyle, do I have a second?
I like the
Second.
second.
Commissioner Akatada. All right, I have a motion and a second. Comments or questions? Commissioner Sargent?
Oh, no, I'm sorry. I was getting off mute to get ready to vote.
If no questions or comments, I will go ahead and take a vote. All in favor of approving the CON, the ongoing?
This is Commissioner O'Connor. I do have one question.
Yep.
This is directed at any one of the guests there about they mentioned national benchmark for mortality rate for STEMI. What is the national benchmark for mortality rate in the STEMI?
Mary Ann, do you want to describe how we rate that, how we evaluate that? You're still on mute if you're talking.
Hello, can you hear me?
Yeah, we can hear you now.
All right, what was the question?
What you mentioned in the report of MMC is similar to the national benchmark for mortality rate for STEMI for 4 12-month periods. What is the risk-adjusted mortality rate for STEMI?
So we look at adjusted mortality rates by 12 months reporting periods. And it's a compilation of results from the hospital's quarterly reports from the ACC and NCDR CAP PCI data registry. And it varies from quarter to quarter.
But give me a rough ballpark figure what mortality rates are for the quarters.
So if I may, Commissioner O'Connor, if you refer to page 17.
17.
Okay.
So we look at if you look at page 17, you see the breakdown of the quarters, and you can see that the quarters that are applicable to this period, which I mentioned briefly in the report, you could see how they compare with the national benchmark and whether or not they meet our MHCC standard based on their confidence interval.
Gotcha. Thank you.
You're welcome.
Thank you.
Are there other questions before we vote? All in favor of approving the application with the condition as recommended by staff, say aye.
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 Any opposed? Thank you very much. The only thing, comment that I want to make about this is if you look at the standard that everybody missed regarding the interventional meetings and reviews, we seem to have that seems to have been a consistent problem amongst most of the application reviews that occurred. are we looking at the degree to which we educate groups with regard to ongoing compliance requirements? It seems like that's an opportunity for us to limit variability in the way that people have approached this. I mean, obviously they're educated now because I think most of our certificates of ongoing performance have included this condition, the same condition in the certificate. But did we look back and see whether maybe we could have been more clear from the start?
Dr. Pollack, this has been Stefan. Yeah, I think that was originally flagged by several commissioners almost at the very outset. And since the reviews, I believe that there's more attention to that. Since the reviews are retrospective, we're not picking that up yet in the reviews that have occurred subsequent to the initial imposition of the condition. But I think the point you're making is a good one, that we could have done more, but the condition itself is now raising awareness on the part of all the programs that that's something they need to pay attention to.
Got it. That makes sense. Thank you. All right, on to agenda item number 4, if there are no objections. The request for a second project change after certificate of need approval for Shepherd Pratt at Elkridge. So Shepherd Pratt is seeking a second project change after CON approval to authorize a higher capital expenditure and alter the funding sources for its replacement psychiatric hospital. Just to be clear, this replacement psychiatric hospital is scheduled to open this coming week in Elkridge. And in order for them to get a final certificate from us, we needed to adjust our agenda to include this item today. Kevin McDonald, CON Chief, will present the staff recommendation. Kevin?
Thank you, Dr. Pollack. Commissioners will remember that in March, you authorized a project change to add $9.1 million to the project budget. And the hospital is back today for a second change. The new change request is twofold. It again seeks an adjustment to the project budget to the tune of $7.4 million. And there's also a change in the source of funds for the project, essentially substituting additional debt of about $26 million for what had previously been described as in excess of $14 million in cash and $16.5 million in philanthropy. To a great extent, some of these changes might be viewed as accounting corrections more than substantive. I would say some are accounting and some are substantive. As described in the staff report, the additional project cost is attributable to an increase in the interest during construction. The project took longer than expected, partially because of the pandemic, and thus accrued more interest during the construction period. This was a fact that Shepherd Pratt overlooked when they submitted their project change in March. And actually it was brought to their attention by HSCRC when they were in the midst of, and I think still ongoing, rate negotiations with HSCRC. So the $7.4 million adjustment in capital cost is due to that increased interest during construction. Turning to the changes in funding, as I mentioned earlier, this is essentially debt substituting for cash and philanthropy in the amount of about $26 million. Instead of the cash that Shepherd Pratt intended to contribute in its initial filing, and as was still reported in March, instead of that cash, Shepherd Pratt used proceeds from a larger corporate borrowing that was not issued specifically for the hospital project, but for a broader array of Shepherd Pratt activities. However, due to cash constraints during the last few years, which were exacerbated by the pandemic, Shepherd Pratt found itself short on the cash that had been planned to go to this project, and instead used funds from that borrowing, classifying that as cash in that case, or considering it a cash contribution. Again, in their negotiations with HSCRC, it was discovered that that really was not an appropriate way to account for that. The project, the reclassification, so that we're reclassifying that portion of the source of funds with $25 million in what's now called a working capital loan. And it's, again, proceeds from that larger corporate borrowing. The change in philanthropy resulted from a decision to allocate only the $5 million that was expressly donated for the replacement hospital, while shifting other donated funds to other capital items. And I guess that was a very recent decision, one that was made after that March change that you approved. These changes and several other operating line items that Shepherd Pratt now projects as being higher have reduced the facility's projected bottom line by about 34%. But the project still projects to show a $2 million profit. In addition, HSCR staff provided us with an opinion expressing their comfort with the financial position of the applicant and the viability of the project. So staff concludes that the project remains viable, and the commission has already found that the project is needed and will have a positive impact on the health system. Thus, staff recommends that the commission approve this second modification request. There are several representatives of Shepherd Pratt available for questions should you have any. Jennifer Wilkerson, Shepherd Pratt's Chief Strategy Officer, Kelly Savoca, their CFO, and attorney Tom Dane.
All right, let's start off. Thank you, Kevin. I'll start off with a motion to approve the request by Shepherd Pratt for a second project change after CON approval.
So moved.
Commissioner Jordan, so move.
O'Connor, second.
O'Connor, second. Okay. Comments, questions by commissioners?
Just a quick one, if I may.
Yes.
I'm just curious, assuming, Kevin, this had all played out from day one, would there have been any issues that, and this is speculation, but would this have caused you any issues that would have changed the original recommendation?
I don't think it would have.
Thank you.
You know, what we would have looked at would have been with the effect of the extra borrowing on the viability of the project would have been the main thing. And it appears that that is not an issue.
Yeah, Chip, when you cut away all of the everything else that's gone on here with this application and the challenge of bringing this forth at the last minute, that's really the only important question to ask, in my opinion. All right, if there are no other comments, I have a motion and a second. All in favor of approving this
Aye.
modification?
Aye.
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 Any opposed? So I just want to thank staff for an outstanding amount of work in sort of turning this last minute challenge around and correcting this. Kevin, I really appreciate it. There was the lack of questions and concerns from the commissioners reflects the due diligence that went into this review. So
Dr. Pollack, if I may, just also on behalf of Shepherd Pratt, thank Kevin and the entire MHCC team, as well as the HSCRC folks who were extremely helpful in getting this work done for today's meeting. So I want to appreciate all of that work. Thank you.
Thank you, Jennifer.
It was fun to have a challenge in the last week.
We wanted to make it interesting for you. Thank you.
All righty. Very good. On to agenda item number 5, which involves data release. Proposed permanent regulations to replace existing COMAR 102505 small group market data collection. So Malit Nagatu, Chief of Public Reporting and Data Release, will present draft regulations, COMAR 102505 regarding data release. Existing regulations at COMAR 102505 are no longer used and will be repealed. If the commission adopts the draft regulations, this action will broaden the scope of permissible use of Maryland Medical Care database data through an expanded and updated data release process and other data sets managed by the commission. The expansion will allow the commission to offer standard, limited, and custom data sets with the capabilities for linkage to other data sources safely and securely, and broaden the potential data recipients to include individuals, governmental, and non-governmental entities. I note that currently regulations regarding data release are located at COMAR 102511 under Institutional Review Board. Those regulations will remain in effect until the commission takes action at a later date. Molly, please proceed.
All right. Thank you, Chairman Dr. Pollack. Can you hear me?
Yes, we can hear you.
Okay, great. Thank you. Good afternoon, commissioners. Like Commissioner Dr. Pollack described, I'll be presenting Title 10, Subtitle 25, Chapter 5, Draft Regulation governing the release of data collected and managed by MHCC. Next slide, please. Here are the regulations comprised in the chapter. In the next few minutes, I'll go over them. However, not in the order laid out in this chapter, but these are all the regulations comprised in Regulation 102505, COMAR 102505. Next slide, please. The purpose of the action for this is to repeal the existing 102505 entitled Small Group Market Data Collection, since the Commission is no longer administering small group market as a result of the establishment of the Affordable Care Act and the Maryland Healthcare Exchange, which now regulates the market. The impetus for the new regulation, as mentioned by Dr. Pollack earlier, is that to expand the permissible uses and the recipients of the data. Currently, the existing regulation only allows use of data for research. It also would allow diversifying the type of data sets provided and also establish a new data fee structure. It would also help in aligning the review standards of the Medicaid data that is housed in the MCDB. Last but not least, it will also increase the transparency and efficiency of the overall application review process. Next slide, please. Regulation 3 covers the types of data sets that will be made available. So namely, de-identified, limited, and custom data set. So de-identified data means it does not include direct or indirect identifiers. Limited data set would include indirect identifiers, which means data elements that could be used to identify an individual when combined with other information or data. That is, in other words, linking with other data sources. Custom data set, as the name suggests, it's a custom data set created on the criteria that's provided by the applicant and is the minimum amount necessary. Next slide, please. Regulation 8 and 9 discuss the establishment of a data release advisory committee, which I'll address as DRAG, that will perform the function of the privacy board as mentioned in the federal regulation 164, 45 CFR 164. The DRAG members will represent various stakeholders, such as academic research organizations, consumer advocates, employers, healthcare providers, insurers, and nonprofit health service plan. The DRAC will be responsible to determine whether an application meets the appropriate criteria, such as whether the data requested is the minimum amount necessary, or if the data management plan documents how the data will be stored and used securely. A more detailed list of criteria can be found in the chapter's Regulation 9. An applicant must provide a written justification if they propose developing or selling a product that contains or includes the de-identified data that they have received from MHCC. The final task for the DRAC after reviewing the application is to prepare a written report and recommendation for the executive director. Next slide, please. Next slide. Thank you. As previously mentioned, can you go back one? Just one. Yes, thank you. Thanks. Okay, yeah. As previously mentioned, one of the goals of the regulation is to align the Medicaid data request process with the commercial data requests. So an application that includes the Medicaid data will be sent to Medicaid for review after it's deemed complete by MHCC. Medicaid is required to respond to MHCC within 15 days on the decision whether to go with an independent application process or whether the application could go through the MHCC review process according to this chapter. Next slide, please. Thank you. In the next 2 slides, we'll look at the two types of requests. The first one being the request from government entities. So governmental entities mean any state government body or the federal government body. So a government entity is required to submit a written request along with the information on whether the data will be linked with other data sources and accompanied by a data management plan. So in terms of the approval, the executive director, the ED, can approve or disapprove or refer the application to the DRAC. And the ED can also further refer the application to a panel of 3 commission members or the full commission for final approval. Next slide, please. So moving on to the request from a non-government entity. Similar to government entities, non-government entities are required to submit a written request and a non-refundable $200 application fee. Once staff deems the application complete, it is transferred to the DRAC for review. The ED cannot approve a non-government application without the DRAC's review and recommendation. Next slide, please. So next is the data request and review process. So prior to review, all applications that are deemed complete are going to be published on the Commission's website. So this is excluding any sensitive information. So this could be like their data management plan or any sensitive information. It's more of like the scope of the project and the expected outcome. The public can submit written comments, and staff will incorporate those public comments in the application package that is transferred to the DRAC for review. Next slide, please. Next slide. Thank you. So looking at the ED's authorities, the ED, for instance, the ED could remand the DRAC's decision, in which case the application is sent back to the DRAC to obtain additional information and conduct a more detailed review. The ED could also reject the DRAC's decision, in which case the ED is required to recommend decision and refer it to the Commission. The ED can also defer the decision of defer the decision to the Commission by referring the the DRAC's written report and recommendation and all public comments to a review panel of 3 commission members. So the panel should include a consumer member. And in terms of the decision, the panel could render the final written decision or could refer the application to the full commission for a decision. Next slide, please. So next is the limitation of the ED authorities. So the ED cannot approve an application that involves the sale of a product that contains the identified data that is obtained from MHCC, in which case the ED should refer the application to the full commission for decision. In terms of notification of the decision on an application, a written decision will be issued to notify the applicant whether it's approved, disapproved, or approved with condition. If there are conditions imposed, the written decision should include that, and also if it is disapproved, the reason for disapproval. Next slide, please. Okay, yeah, so an applicant could request request a review of the decision on the requested data. So there could be these are like 2 types of requests. One is requesting for further review if the written decision was issued by the ED. In that case, the applicant is required to submit a written request, and within 20 business days once the decision is issued. The other is requesting for reconsideration of the decision if the decision on the application is made by the commission. Also, in this case, they are required to submit a written request, and the commission will review the request and for reconsideration of its previous decision and issue a written decision affirming or reversing or modifying the previous decision. Next slide, please. So moving on to Regulation 12, which covers fee structure and fee waiver. As I mentioned earlier, a list of fee will be published on the Commission's website, which will be reviewed and updated annually. An applicant could request a fee waiver, and the fee waiver request should include information on the reason for the request and also document the application's inability to pay part or all of the required fee. They provide a justification for their request, basically. An ED may grant a fee waiver if the ED determines that the fee waiver is in the public interest. The ED may consult the panel of the commission members or the full commission for a waiver as well. Next slide, please. Yeah, Regulation 13 just covers the components of the data use agreement that a data recipient is required to enter with MHCC. So these are things like terms and conditions governing storage, destruction, and notification to the commission, or the need for the disclosure of funding sources and any conditions that are specified to the funding source if the applicant is funded by a different entity. It also details out the need for a new application if there is a scope of work change or any kind of additional details specific to that application and project in terms of like additional data, execute a revised data use agreement, and like application fee and other details. So the ED may consider, if an applicant requests an extension, an ED may consider a request from a data recipient for an extension of time on the modification of the terms and conditions of the executed data use agreement, which could include just a simple extension to use the data for a couple of more months, or a scope of change in the project itself. Next slide, please. And the last regulation refers to the compliance and enforcement. So the commission may take appropriate administrative and judicial action if, for instance, the data recipient does not comply with the terms and conditions that are specified in the data use agreement, or also if the data recipient provided false information during the application process, and that is found after the DUA is executed. So the ED may refer any instance of unauthorized access to the listed offices, and also the commission does not have, this is one of the things that an outcome from our discussion with the work group, the commission does not have an authority to impose fines for any data recipients that violate the data use agreement. So as part of this, the recommendation, staff recommends that the commission seeks statutory authority to impose fines. With that, I complete my review of the regulation, and staff recommends that the commission repeal the existing regulation COMAR 102505 and adopt the new regulation 102505 covering data release as proposed regulation. Thank you.
Sorry, looking for my mute button there. So do I have a motion to adopt the new 102505 and repeal the prior 102505?
So moved. O'Connor.
Second, Commissioner Thomas, second.
Okay. Motion by Thomas, by O'Connor, second by Thomas. Discussion, questions?
I had one just procedural, because we talked about these as proposed permanent regulations. Does that mean this is our final vote and these go into authority automatically after a certain period of time? Or is there another stage?
So,
Ellen, oh, I'm sorry.
So,
go ahead.
Mahi, answer, please.
So I'm very new to this. So next step for this is for the proposed regulation is to be sent, once it's adopted, it goes to the governor's office for approval and sign off to be published on the Maryland Register for comments. And then it comes back to the commission to be adopted as a permanent regulation, is my understanding. So then.
Thank you.
Sue Ellen, do you have anything to add?
No, I mean, it's clear that it's not the final regulations, it's just proposed, finals later. So,
And just to be clear, the last slide, item D, staff recommends the commission seek statutory authority to impose fines. That requires additional statutory authority.
Correct.
Okay. All right.
What that, Dr. Pollack, what that fine that could be? Do we know?
We would need to seek the statutory authority. That means we have to go to the legislature separately and ask for statutory authority to impose fines. We would have to determine that at a later date.
Okay, thank you.
If there are no other questions, I will take a vote. All in favor?
Aye.
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 All right.
I'm hearing background noise. I can't tell if that is somebody voting or not, but it sounds like not. Any opposed? Very good. So we'll wait for the final to come back from the governor's office.
Dr. Pollack, I want to bring to your attention that Dr. Bhandari has joined the meeting.
Yes, thank you. He sent me a chat and we recognized his question minutes ago, but I failed to welcome him publicly. So welcome, Dr. Bhandari.
Thank you so much.
Agenda item number 6, MDPCP Advisory Council term renewals and nominations. So the Maryland Primary Care Program is a key initiative under the total cost of care model that provides funding and support for the delivery of advanced primary care. In January of 2019, the Secretary of the Department of Health requested an advisory council be convened by MHCC to serve in a consultative and advisory role to the Secretary and the MDPCP Program Office. Anina Onyabo, Program Manager in the Innovative Care Delivery Division, will present 2 advisory council reappointments and nominations for commission consideration. Anina, please proceed.
Good afternoon, Mr. Chair and Commissioners.
Good afternoon.
In spring 2019, you approved nominees for the Maryland Primary Care Program Advisory Council. The council convened its first meeting in October 2019. Since then, the council has met 18 times in December 2019, 16 times in 2020, and in May of this year. As the chair mentioned, the MDPCP provides funding and support for primary care providers to advance primary care by improving access to care and continuity, care management and coordination, and beneficiary and caregiver experience. The program is a key initiative under the total cost of care model. Next slide, please. Thank you, Lavon. Next slide. The purpose of the Advisory Council is to provide input on MDPCP operations and to serve as an advisor to the Secretary and the Maryland Primary Care Program Management Office. Next slide. MHCC consults with the PMO and provides support to the council for the activities outlined in this slide. Next slide. Thank you. Mr. Chairman, on the following 4 slides, I will present the reappointments and nominations individually, and then pause for commissioner action at the conclusion of the 4th slide, unless you prefer a different approach.
No, I think that's fine. Thank you.
All right. Next slide, please. Dr. Barrington has 20 years of experience in primary care and has served on the council since it was formed. He has an extensive clinical background in primary care, as well as providing policy analysis and healthcare delivery issues. Next slide, please. Ms. Cohen is the Executive Vice President of Medical Affairs for CareFirst. She has held leadership roles in a wide array of health management programs, member engagement and experience, provider engagement, compliance, operations, and analytics. Ms. Cohen has been on the council since it was formed. Next slide, please. Dr. Gary is the Vice President and Medical Director of the University of Maryland Medical Systems Population Health Services Organization and President of both the Quality Care Network and Care Transformation Organization. She leads the planning, development, and execution of value-based population health initiatives and innovations at UMS. Next slide, please. Ms. Logren has worked at AmeriGroup for 17 years, representing the MCO before Maryland legislators, governors, regulators, and key stakeholders. Next slide, please. We recommend that the commission approve the reappointments for Dr. Berenson and Ms. Cohen and the nominations of Dr. Garrett Ray and Ms. Logren. I'm happy to take any questions you may have at this time. The appendix provided to you includes a table of current council members, discussion items from quarter 3 and 4 of 2020, and a link to council meeting summaries.
Thank you. And do I have a motion to approve the MDPCP Advisory Council term renewals and nominations for these 4 individuals?
Aye.
Second.
So, thank you. Discussion questions? Ben, you serve on this MDPCP advisory panel representing us. Do you have any comments about these individuals? They seem you're comfortable with them.
Dr. Pollock, I'm very comfortable with the two that are up for reappointment. We've gotten very strong recommendations for the new appointees. I'd also note that David Sharp is the co-chair with Dr. Michael Reedman and works closely with all of the commissioners. My observation on the council is that it's somewhat more heavily weighted towards the providers. So Ms. Cohen represents a minority view on, as there are fewer payer representatives on the council. Dr. Berenson is a strong advocate of primary care, but a skeptical observer of recent innovation, Medicare Innovation Center advanced payment models. So he provides, I think, a very critical piece of input as he is number one, a provider, but also a experienced health policy expert to provide some guidance to the council. I think that the two new representatives are going to represent, in the case of Dr. Jarrett Ray, a very important participant in the program. And AmeriGroup, although they are not currently participating in the MDPCP program, Secretary Schrader has made it priority number one, or maybe I should just say a very high priority, to bring the MCOs into the program. I note that among the other 25 or so states that have such programs, virtually all of them have MCO Medicaid participation. Maryland was actually allowed to have this program because it was judged key to the total cost of care model, but it is a bit unusual to not have either private payers or the MCOs participating. And clearly, if this is to succeed, both of those important groups are going to have to join the program over the next several years.
So, Mr. Stephan, what was the reason MCOs and private payers was not part of it? Was it due to the financial issues or some other issues?
Well, I think financial issues are always major factors. The challenge for the private payers, I think, has been that they argued that they have similar but not identical programs, and to align with the MDPC program would be at least initially argued as adding some additional complexity, and in other cases some duplication to what they were already doing. I think that thought is being revisited. With regard to the MCOs, the fear on the part of the MCOs and indeed the Department of Health has been that until it's clear that this is a money-saving program, adding additional funds to the Medicaid budget to cover the additional cost of the MDPCP program is a significant budgetary issue for the state. It's been argued, and there is some evidence in other states that Medicaid programs do save money through these programs, but it is not universally the case.
Thank you.
Thus the hesitation.
Thank you.
Thank you, Ben. Other questions? Hearing none, all in favor of the nominations?
Aye.
Aye.
Aye. Aye.
Any opposed? Congratulations. Agenda item number 7, the medical care database data release to CRISP. So under current statutes and regulations governing access to the medical care database data for research use, the commission must approve an application for medical care database data prior to the release of such data to an applicant. Chesapeake Regional Information System for our patients, CRISP, has applied for the MCDB data. Mahi Nagatu will present the staff's review and recommendation for the application. Mahi, please proceed. Again.
Thank you. All right, next slide, please. Thank you. Yes, so just as a refresher, the current regulation also requires an approval or an approved IRB approval from a recognized entity that's recognized by the commission. It also, the application, the applicant and the application should also demonstrate that the proposed research use of the MCDB data is in the public interest. The applicant must also submit a data management plan that adequately describes the data security, the safeguards and protections they have in place in order to house and use the MCDB data securely. The entity should also enter a data use agreement with the commission that includes required terms and conditions to set out that are set out on the commission's regulation. Next, please. This application is, as mentioned earlier, submitted by CRISP for a project that they're working on with our sister agency, HSCRC. Next slide, please. The project proposes, according to their application, to compare Maryland Medicare and commercial spending on ambulatory surgery by Maryland region and in comparison to the national average. And the second aim of the project is to investigate the impact of Maryland's effort to improve care delivery and outcome related to first episode psychosis through the implementation of evidence-based treatment. The project data sources, of course, includes the MCDB data, Medicare and Medicaid. Project is internally funded. So when looking at the proposed project detail, particularly A1 related to the ambulatory surgery, the goal is to look at Medicare, Medicaid, and commercial claims that will be used to identify surgical procedures performed in hospital, outpatient, or ASCs. It would look at demographic characteristics and also capture the pre and post 90-day and the procedure itself encounters, so that there is a look back and look forward window to identify the encounters in the services. Next slide, please. So looking at the second aim, which is related to the FIP, it would look at analyzing the outcome in relation to the receiving coordinated specialty care, which is to compare the frequency of each outcome for enrollees with FIP who receive CSCs compared to those who have not. Data requested from MACC include the years from 2015 to 2020. The project outcome is expected to be disseminated on the CRISP website as 2 independent white papers. The data, in terms of data fee, the applicant has requested a fee waiver for the standard fee of $19,000, which is for the multi-year data that has been requested. Next slide, please. So we have some of the team members with us today. Jessica Heslop, that's the program manager and the primary applicant and researcher. Megan Priello, Senior Director of Population Health at CRISP, who's also the contact person. George Chaliseri, who's the CEO of H-Metrics and the data custodian. Richard Johns is the Executive Director and the AGS data custodian. Ricky Ip, the Data Security Officer and the data custodian for Acumen. Next slide, please. So moving on to the review and recommendation, staff considers the application meets the regulation requirement of being a research for research use because the project compares Maryland's Medicare and commercial spending in ambulatory surgery and Maryland region in comparison to the national average. And also looking at the FIB, it looks at improving the care delivery and outcome related to the episode through the implementation of evidence-based treatment. It also meets the public interest as it will enable a better understanding of the key questions related to the total cost of care and care transformation, and thus improve the capabilities available to support those efforts across the state. In terms of recommendation, staff recommends that the commission votes to approve the MCDB data request application submitted by the applicant, CRISP, and provide access to the requested data contingent on the data use agreement that CRISP will enter with MHCC. Staff, in addition, recommends that the commission grants the applicant the fee waiver that's requested for the amount of $96,000. Next slide, please. That concludes the review of the application. Welcome any questions for the project team and staff. Thank you.
Before questions, do I have a motion to approve the MCDB data request application from CRISP and to provide them access to the requested data contingent on the data use agreement and also to waive the requested or to approve the requested fee waiver of $96,000. Is there a motion?
I'll make a motion.
Commissioner Boyle?
Yes.
Is there a second? Second, Commissioner Dordan?
Yes.
Very good. Any discussion? Hearing none. All in favor?
Aye.
Aye.
Dr. Pollack, I have just a question. From where this fee is going to be if it's waived?
Say that one more time.
They are asking for the fee waiver.
Yes.
So from where this money will be contributed from some other sources or it's not required?
Mai or Ben, do you have a comment on that?
So the fees that we charge for access to the MCDB cover the cost of developing the data from the submissions made by payers. And in this case, this cost would be absorbed through the commission's budget. There's no other alternative, but this waiver, given that it's designed to support research for required by CMMI under the total cost of care, we think is justified.
Thank you.
Thank you. So I have a motion and a second. Absent additional discussion, all in favor?
Aye.
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 Great. Any opposed? All right, I want to stop now to congratulate staff and commissioners. We just made it through 6 agenda items in an hour and a half with some fantastic presentations. And I think that's a testament to focus and preparation. So thank you to everybody. On to agenda item number 8. We're, I think, through the action items on the agenda and on to informational items. The agenda item number 8 is the presentation of the MHCC logo design. Shade Paul, Program Manager for Governmental and External Affairs, will give a presentation on the new MHCC logo. Shade, please proceed.
Thank you. Good afternoon, Commissioners. Can everyone hear me?
Yes, we can. Thank you.
Great. My name is Shade Paul, and I will be presenting on the MHCC logo redesign. Next slide, please. Currently, The Maryland Healthcare Commission has not one, not two, but 5 logos that represent the commission. Here, you see each of the logos, 3 with variations of blue colors and 2 with the Maryland colors. The 3 blue logos were designed over the past 10 years, and the 2 Maryland colored logos were designed in fall 2020. These are the 5 logos that we know about. Who knows? There are probably other logos out there that we do not know about. Next slide, please. We have so many logos. Why do we need another one? First, the commission logo represents our brand. Our brand communicates our story, who we are, what we do, and why it's important. Having multiple logo variations sends an unclear message. It is confusing, not only for our internal staff at the commission, but also for our external stakeholders. In addition, there is inconsistent use of these 5 logos. The logo on our Facebook page is different from the logo on our main website, and both of these are different from the logo on our digital marketing platform. As previously mentioned, the blue logos are outdated. They are over 10 years old. None of these 5 logos tells the story of MHCC. The Maryland colors are our state colors, and the letters M, H, C, C are our acronym. But these design elements don't immediately communicate our mission, our values, or our work within the healthcare landscape in Maryland. Next slide, please. In November 2020, the commission undertook a project to develop a redesigned logo, one consistent logo that would replace all existing logos. We developed an RFP and formed a small team of 3 reviewers to evaluate proposals. Overall, we reviewed 20 proposals from contractors who have worked with healthcare agencies, both public and private, across Maryland. In February 2021, we awarded a contract to Hatcher Group. We formed a new team consisting of center leadership and the executive office. We worked with the Hatcher Group to begin designing a new logo. In total, the logo redesign team reviewed over 30 variations of logos. In March 2020, we solicited staff feedback on preliminary drafts of the new logo. The logo represents everyone at the commission, so it's important for us to incorporate staff feedback, both negative feedback and positive feedback, in our decision-making. In June 2021, the logo design and templates were completed. Next slide, please. The logo redesign team had specific asks and deliverables for this project. Primarily, we wanted a logo that communicates the story of MHCC. The logo needed to represent the following attributes: quality, availability, accountability, transparency, stability, and integrity. It also needed to be visually appealing, modern, clean, and simple. It would also need to contain the word Maryland without diluting the existing MHCC acronym that we are known for in our branding. The project deliverables were clear. In addition to the new logo, we wanted branded templates for PowerPoint and Word. We needed updated envelopes, business cards, and an email signature. And finally, we requested a brand guide to assist MHCC staff and contractors in their use of the new logo and template. So, without further ado, I am thrilled to reveal the new MHCC logo. Next slide, please. The new logo for the Maryland Healthcare Commission should feel familiar to Maryland residents as it contains the Maryland state colors. It also contains the word Maryland, but structured in a way that doesn't overpower the Healthcare Commission wording. The 4 squares contain 4 icons, each one representing one of the 4 centers within the commission. The hospital cross represents the Center for Healthcare Facilities Planning and Development. The star represents the Center for Quality Measurement and Reporting. The arrow represents the Center for Health Information Technology and Innovative Care Delivery. And the 3 bars represent the Center for Analysis and Information Systems. The clean and structured geometry of the icons on the left and lettering on the right speaks to MHCC's role in improving the regulation and quality of Maryland's healthcare system. Combined, the icons and the lettering create a clean, modern, and representative logo that tells the story of the Maryland Healthcare Commission. Staff feedback on the logo was generally positive. One staff member said, components of the Maryland state flag are recognizable, while another said, visually, I like the colors, the boldness, and the symmetry of the design. Next slide, please. The new logo is also available in non-color versions. These versions will be used selectively and only when appropriate. Next slide, please. So, what is our next step? Next slide, please. One more click, please. Thank you. We go live on July 1st. On this date, all previous iterations of the MHCC logo will be replaced with the new logo across all of our websites, social media pages, email signatures, and templates. The style guide will be disseminated to staff at the all staff meeting in July to guide their use of the new logo. Next slide, please. Thank you to everyone involved in this project, specifically Ben Steffen, Teresa Lee, Tracy DeShields, Richard Proctor, and Dee Stevens. Thank you to the MHCC IT staff for their guidance on digital implementation of the new logo. Thank you to all MHCC staff for providing your support and feedback throughout the lifespan of this project. And thank you to Lavon Ward for advancing the slides throughout this presentation. I'm happy to take any questions or comments.
Shade, this is Commissioner Wang. I just want to say I commend you on a really wonderful presentation just now. Very clear. I've seen a lot of brand logo presentations and you've done a really great job. So congratulations.
Thank you so much.
Ditto that. The enthusiasm was fantastic and contagious. Thank you.
Thank you. I appreciate it.
I'd just like to make a comment. Congratulations. I agree. You did a wonderful presentation and everybody did a great job in developing it. The components are interesting, representing the values. And there's some people who probably wouldn't understand what all of the symbols mean. Will there be any ability on the website or something to explain, maybe if you click onto the logo, explain what it means? Because I think the symbolism is wonderful, but not everyone might understand it all.
Thank you so much for that comment and that question. I agree. I think it is difficult to know that we were thinking intentionally about the icons by just looking at the icons. I think there's definitely room to create some type of link or a web page on our main website to explain all of the icons and the development process while we roll out the new logo. I think that is a great suggestion and it's something that we can work on developing.
Actually, I agree with Commissioner Boyle's suggestion. If you click on the icon, it should tell what that means, because I was clueless. I was going to ask you that question. Before I asked that question, you already said what these mean.
Oh, yeah. Yes.
And what was the reason Maryland flag was taken out? I actually like Maryland flag one also. It represents state of Maryland.
We also like the Maryland flag. We have nothing against the Maryland flag. I think we didn't want it to be so literal. We didn't want to to seem like an agency that only represented seemingly the Maryland flag. We had elements of the Maryland flag. We had the colors, and in earlier iterations of the logo, the Maryland flag was a lot more prominent. And so the team had very deliberate conversations about how much of the Maryland flag do we want in the logo. And so after a lot of conversation, we really wanted MHCC as an agency and our story to come forward. We wanted to hint towards the Maryland flag, as you can see with the colors. But we really did want MHCC as an agency to kind of come forward in the logo. And I think the team did a great job on doing that. And maybe that explanation can be included if we do have a web page to show that we're launching the new logo, to just explain what the elements of the Maryland flag are in the logo. But we do just want to make sure that we're pushing that this is an independent agency. This is our new logo. We are very proud of it. And it also has elements of some historic Maryland flag elements in there as well.
Thank you. I'm going to re-echo what Commissioner Boyle said. If you hover on those icons, they should come, what that means. That will be a wonderful thing if you can do that.
Okay, thank you so much.
Sade,
This is I'm sorry, this is Commissioner Reimer, just a quick question. What is it going to be the cost associated with transitioning to that new logo? I mean, obviously, we're fortunate to have a lot of stuff digital where we can print, but is there any large costs associated, any signage or anything else that has to be replaced?
Yes, that is a great question. We were mindful of costs, not only when we were securing Hatcher Group as our contractor. As I mentioned, we reviewed multiple proposals and we selected Hatcher Group because they had a competitive price. Also, the quality of their work kind of substantiated the price that they were asking for. And they had recently done a logo redesign and a branding project for our sister agency, HSCRC. So we knew that they were going to do a great job for us. But yes, price was a consideration when we chose our contractor. Now, when it comes to implementing the new logo, we have a team, we have an incredible IT team in-house that hopefully, I don't want to put anyone out there, but that can hopefully help us to go through the process of rebranding everything across all of our digital footprint. And we have been discussing, in terms of additional costs, merchandise for MHCC staff and commissioners. So we have been talking about maybe a t-shirt or a tote bag or a water bottle, a branded water bottle. So we've been talking about some branded items that we can have available. So that will incur a little bit of cost. We are currently, I mean, when I say currently, I was working on this earlier today. We are currently working on a merchandise cost review. So we are looking at all of the competitors out there. Hatcher Group gave us a short list of merchandising companies we can look at. So we are comparing prices for some of these items, the t-shirts, the water bottles, these things. And we will go with a company that is that kind of adheres to our budget that we will create for this, and that also has great quality, products. So to answer your question, I know that was long-winded, but we have been mindful of cost throughout this whole process, and as we kind of wrap up, the project, we are also mindful of cost when it comes to implementation and any merchandising that we're doing as well.
I think both Tiffany and Louis Vuitton will do some custom stuff for us if you want.
If you have contact information, please let us know.
I'm sure they're on
We'll reach out.
contracts already. Yeah.
Okay.
Thank you very much today.
Thank you.
Next up, on May 3rd, staff released an announcement for grant applications advancing practice transformation in ambulatory practices. The announcement seeks to identify one or more care transformation organizations, or CTOs, to complete practice transformation activities to qualifying primary care and specialty practices. The grant supports the broad goals of the total cost of care model by preparing ambulatory practices to participate in new models of care delivery. Melanie Cavalieri, Chief of Innovative Care Delivery, will provide an overview of the grant and recipient of the grant award. Melanie, please proceed.
Good afternoon, Mr. Chair and Commissioners. As mentioned, I will be announcing the awardee for the Advancing Practice Transformation in Ambulatory Practices Grant. Next slide, please. In May, staff released a grant announcement to identify a CTO to engage primary care and specialty practices in a practice transformation program. In addition to supporting the broad goals of the total cost of care, the grant objectives include preparing practices to deliver efficient, high-quality care while improving health outcomes and laying the foundation for practices to provide team-based, patient-centered care and efficiently use health IT. Next slide, please. Total grant funding available is up to $500,000. A CTO can earn $9,800 per practice for completing program milestones. Participating practices may receive up to $1,000 for completing 4 quarterly assessment questionnaires. Next slide. This slide contains a breakdown of milestones and payments. All payments are made directly to the CTO. The first and third milestones, the readiness assessment and training, are based on the CMS TCPI model. TCPI was one of the largest federal investments uniquely designed to provide technical assistance to clinical practices. It created a nationwide collaborative peer-based learning network to facilitate large-scale practice transformation designed to prepare practices to successfully participate in value-based payment arrangements. TCPI was designed to support more than 140,000 primary and specialty clinicians who were not participating in value-based payment arrangements. It was conducted over a 4-year period to share, adapt, and further develop comprehensive quality improvement strategies. It comprised one part of a nationwide strategy to strengthen the quality of patient care and spend healthcare dollars more wisely. An article from the Annals of Family Medicine published in August of 2019 noted the following. TCPI identified best practices for preparing both specialty and primary care clinicians for participating in APMs in public and private sector. Practices that graduated from TCPI are well positioned to participate in APMs, including the new models announced by the Innovation Center. The awardee anticipates conducting training on the TCPI modules through a mix of virtual and in-person trainings. The group transformation activities may include up to 5 practices. While the grant period is a 24-month window, we expect that the milestones for practice transformation activities will take 12 to 18 months. The workflow redesign modules use ONC templates as a foundation. ONC notes that workflow redesign can help organizations maximize efficiencies, enhance healthcare quality and safety, and improve care coordination. Next slide, please. There are 24 CTOs in Maryland. Staff received a letter of intent from 14, and 10 submitted a completed application to be considered for the grant. The 10 CTOs identified over 400 target practices. The grant funding is designed to support up to 50 practices. MedChi CTO ranked ahead of the other applicants. The application recruitment period is a 60-day window that will allow MedChi to enroll up to 50 practices. If they do not enroll 50 practices during that period, MHCC will consider awarding the next highest ranking CTO. Next slide, please. I will now tell you a little bit about MedChi CTO. They currently partner with 25 MPPCP practices. From 2016 to 2019, MedChi was a collaborator in the CMS PTN efforts in Maryland, which included MHCC in the University of Maryland School of Medicine. During that program, MedChi was instrumental in recruiting and facilitating transformation for 836 practitioners in 109 practices. Next slide, please. This slide shows the next steps. Staff will be completing administrative award activities. A program kickoff meeting is planned for mid-July. The 60-day practice recruitment period will begin around July 19th. Practice selection and notification is scheduled for August and September. Milestone 1 readiness assessment activities will be initiated around early October. Next slide, please. That's the end of my presentation. The appendix contains information on the program milestones. I'm happy to answer any questions.
Any questions from commissioners for Melanie? Congratulations to MedChi. Any other questions, comments?
Melanie, I have a question. How many physicians they are looking for? I know they are looking for 50 practices. Is there a number of physicians?
There is not a specific number of physicians, but we would anticipate these will be probably smaller practices, maybe 1 to 2 physicians per practice. So I would say that, that's practices on the smaller side. We are not limiting the number of physicians per practice that may be enrolled.
And we are not. Do we have a target number of physicians for the award for the 50 practices? Has to be like the previously you mentioned 836 providers were enrolled. So do we have any target number for that also?
We do not have a target number. We are more concentrating on the practices that are going to be prepared to participate in the models going forward.
Thank you.
Thank you very much, Melanie. Moving on, agenda item number 10. Center for Healthcare Facilities Planning staff will now brief the commission on 3 innovations that touch on areas of commission authority and are consistent with the state's goal of promoting greater integration and innovation to meet the objectives of the total cost of care model. After introducing these initiatives, we'll have an opportunity for questions and discussion. So Linda Cole, Chief of Long-Term Care Policy and Planning, and Paul Parker, Director for the Center for Healthcare Facilities and Development, will present. Linda, the floor is yours.
Thank you, Mr. Chairman, Commissioners. Can you hear me?
Yes.
Good. Paul and I will briefly present some recent commission innovative initiatives that cover a range of provider types and settings. Next slide, please. First, I will discuss the Hospice Health System joint venture, which represents a care delivery innovation. Then Paul will present the hospital at home and ambulatory surgical facilities innovations. Next slide, please. Based on some initial meetings and reports of interest on this subject, on May 20th, Commission staff posted on its website guidance regarding joint venture projects between licensed Maryland General Hospices and licensed Maryland hospitals or health systems. The objective is to permit such joint ventures in order to provide a more comprehensive array of services in the home, in the community, and in facilities. The focus is on reducing the total cost of care and aligning with the state integrated improvement strategy. It also supports the Commission's intent to develop innovative models for healthcare delivery under its statutory authority. In discussions, staff determined in consultation with counsel that this could be done through a request for determination of coverage and would not require a CON. The key features include, as I mentioned, the joint venture includes a licensed Maryland General Hospice and a licensed Maryland hospital or health system. The hospice services must be provided by an existing Maryland hospice provider with at least 5 years of experience. Such a joint venture cannot create a new licensed hospice. The provision of care is limited to those jurisdictions where the hospice is already authorized to provide care. The joint venture must fully detail the inter-provider partnership and cost-reducing agreement designed to lower the total cost of care for patients receiving hospice and other health services provided by the joint venture. And finally, if the joint venture ceases operations, any authority that involved the provision of hospice services would revert back to the existing Maryland General Hospice. The commission currently has received a proposal from Gilchrist Hospice and Luminous Healthcare to provide services under a joint venture in Anne Arundel and Prince George's counties. This proposal is currently under review and no action has yet been taken by commission staff. I will now turn it over to Paul to discuss hospital at home.
This is Paul Parker, Director of the Center for Healthcare Facilities Planning and Development. I assume everyone can hear me. And before we proceed with the next slide, Commissioner Pollack, since we're covering 3 areas, do we want to pause for questions on this first innovation or proceed with the rest of the slides?
Why don't we, I think it's a good idea. Why don't we pause and see if there are questions on the expanded use hospice first. Any comments, questions?
That's the only question I have is obviously this is is this just a pilot project right now that we're going to be looking at to see the results, and how long would that be? Or is this something that we're going to be getting back to us with a formal proposal on?
We've just received a proposal. We're in the process of reviewing it. This is being provided for information as far as innovative projects. We can provide more details once we have it.
So is this something we would eventually approve, or is this something?
No. There will be staff action. This is just being presented in the context of innovative models that are being done. Basically, it's a staff review for determination of coverage.
So if I could interrupt you, Linda, so commissioners have thoughts. I mean, clearly the 2 entities in the joint venture have put this forward. We are intending to make this, the fact that this is occurring, available to the industry. If the commissioners have thoughts, for example, if the commission staff under our authority issued a determination, be sure to require some, perhaps not a full evaluation, not a full program evaluation, but provide evidence on the success or lack of success on this project that then could be embedded in our processes going forward. Obviously, this is something that was generated from the industry, which we really like. There's been much innovation here in Maryland over the last 4 or 5 years, but it's been people like David Sharp and Melanie and Ben Steffen and HSCRC postulating what would be innovative. And I really like all of these ideas because they're industry generated rather than bureaucracy generated.
Right. I think it's a great idea. And I think this is an area that would be a win-win for hospitals and hospice. So obviously we're not the HSCRC, but on the funding side, are they allowing some flexibility for the hospitals and hospice to work together as far as a reimbursement kind of thing, where there's savings that could be shared and that kind of thing? Or is this like, am I stepping way ahead of the game here?
This is Paul. If I can try to respond to that. To get back to your first question, this is not a pilot. We're not trying to set up a demonstration here. We've established a policy that allows joint ventures to come to us and seek to get this type of determination of coverage. As far as payment, the joint venture will be a provider of hospice services. And so there's a couple of other key players here who have to be receptive to our policy change. And we're still waiting for that to officially happen. the Maryland Department of Health licenses hospices, so they have to agree to follow the model that's outlined in our guidance and allow licensed general hospices in Maryland to use the license, the hospice license authority that they have, along with the authority that we gave them as the Maryland Healthcare Commission to serve certain jurisdictions, allow that to transfer to the joint venture. So the joint venture would then, a key reimbursement question would be the joint venture being able to obtain CMS certification as a provider of hospice services. And that would be a separate certification from the hospice, the general hospice. And that is an overwhelmingly important payer for hospice services. So those things are going to need to happen too, and they're not under our control. And those agencies are going to have to allow this, find the flexibility under their statutes and regulations to allow this.
I have a quick question. If the floor is free.
Go ahead.
Okay. So Ms. Cole,
Yes.
don't you remember the work we did, our little listening tour, or addressing the issue of the underserved populations, the fact that African Americans were not being served to the capacity with hospice? We had a long discussion. We did a listening tour. My question is this to both you and Mr. Parker. Does this joint venture help solve that problem?
I do recall our listening tour, as you put it, basically hospice education and outreach. And I think that this is an effort in the jurisdictions identified to provide information on hospice as well as palliative care and hospice services.
So you believe this joint venture addresses the health disparity, the racial disparity gap that you and I heard as we went around in our listening tour?
Some of that will be seen in the implementation, but I think it is an effort to make the community more aware of hospice services. And they're also trying to provide a full range of geriatric services for chronic conditions. So I think it includes pre-hospice as well as hospice services within the continuum of how to deal with chronic care, how to reduce hospital admissions, how to provide more palliative care.
Thank you very much.
Yeah, I think this kind of flexibility in model design really has a tremendous capability of increasing the number of populations that are served, number of populations that become aware of the service, the number of populations that have access to the service, and therefore potentially addressing those healthcare disparities, as you know, probably better than anybody else, actually addressing them and fixing them is a lot harder than just trying to do that. So we're going to need some flexibility, some different models, and we're going to have to try some things along the way. And I don't think anybody has an answer yet to exactly what we need to try to be effective. But in order for us to try different things, we need more flexibility in the models, and this is exactly that.
Well, I like that, and these providers are in the very jurisdictions where the communities we're concerned about live. Just the pandemic has made me realize that the more intentional we are, the better. So, we wouldn't want to leave it just to the subtext. So as they implement this, we should be watching for how they tailor things to address the concerns that we have identified and raised. But the flexibility helps them do that. That's great. Thank you.
Yeah, I think that's a good point. I mean, we can certainly not just provide the flexibility, but encourage it and ask about it and monitor it and follow it along the way.
This is Commissioner Bandari. I work with hospice more than many physicians because of the nature of my practice. My question is, at Luminous Health is going to have joint venture with Gilchrist. So there are already some pre-existing hospice, like I can say in Anne Arundel and PG County, Hospice of Chesapeake is there for a long time. So when they make this joint venture, do they look at who is a major player already, or they want to bring somebody else to create more competition? Because, Gilchrist, I don't know how much, they have services in this area. And second thing is, as a provider, am my hands are tied that I have to work with now Gilchrist, or I cannot refer to other hospices with I'm working for last decade or longer?
I think these are questions that the provider will address in terms of the implementation of the project. They're trying to expand the services at the 2 hospital sites, the 2 Luminous hospital sites.
Dr. Bhandari, this is Paul Parker. I would say that when you look at this specific first request for determination that we received, from a business standpoint, yes, I think it, to me at least, based on what I know about hospice operations and market share, this is a joint venture that, if it's successful in kind of developing the way it wants to, would probably provide more competition in those 2 jurisdictions. And Gilchrist is a large hospice operation that has focused on other areas of the state more so than these 2 jurisdictions. So it would provide some competition for the market share leaders in those areas. But we think there's nothing wrong with that. And as far as you being tied down, I think, we're not trying to affect, the authority and the ability to successfully operate of any other hospices. They will perhaps face some more competitive pressure in their operations, but certainly we would not want joint ventures to create an inflexible situation where patients cannot, obviously engage with any hospice provider they wish, and that their physicians also are able to participate in provision of that service.
I think some of the hospice are for-profit, some are non-profit. I don't know about Gilchrist, but I can say hospice of Chesapeake is non-profit.
Gilchrist is also.
The only other comment I want to make, this is Martha Reimer. In a rural community such where I live in Calvert, this actually is a pretty good model. And the reason for that is that the hospice, we basically have 1 provider in our community, and they are pretty much left up to, the hospitals and the physicians to refer. And there is that constant concern whether or not we're serving all the patients appropriately over a much larger market area. Our geographic area is very large. So what I see this would be very helpful in a community like that, because you could integrate with the hospitals to make sure that the same goals are in place for that referral, where you're actually going to give the hospital some incentive and then be able to use the services of hospice and palliative care in a much better way for the community. Right now, it's difficult, and there's just not a lot of a good working relationship. So I think a joint venture in a small community actually makes more sense. So I'm excited to see that, and I'm going to personally take this back to our hospice and our community and talk to them a little bit more about that. See if this would be something they can look at.
So we have posted this on our website, and we have made the community aware of it. And so hopefully we'll be getting additional proposals.
All right. Paul, you want to move on to hospital at home?
Yes. Can I have the next slide, please? So the hospital at home concept has a bit of an evolutionary history. I think the most recent series of evolutionary events kind of began in the late 1990s. There was a lot of academic research on this concept. What type of patients does it make sense for? What are the clinical criteria that we would want to use? How do we pay for the service? And then in the 2001 to 2004 period, there was CMS, demonstration. I believe that's one that Johns Hopkins participated in, and they are clearly, you know, a Maryland leader in promoting this concept. About 10 years later, there was a second demonstration, this time specifically under CMMI, you know, a part of CMS that came to the fore after the Affordable Care Act. And we are now at a point recently with the pandemic where CMS created a waiver program allowing hospitals to use the hospital at home concept as a way of decanting bed use at the hospital, freeing up more beds for the pandemic emergency. So the concept here is allowing acute general hospital inpatient care to be provided in the patient's home. And so in our recent General Assembly session, the Budget and Tax Committee inserted language that mandates a study report to be jointly done by HSCRC and MHCC. It specifically is a report that's supposed to answer the question of, is this an efficacious model? How does the model fit into the total cost of care model? What barriers to the model exist in Maryland's law and regulation? And then what are the cost implications of the hospital home model for payers? And that report will be due in December of this year. The LEF hospital at home model is a reference to Bruce Leff, a geriatrician who was a leader in the work by Johns Hopkins Medicine earlier in this century on that model. And under the LEF model, the specific gains that we hope for are reduced care cost, equivalent or improved outcomes for the targeted patients in terms of both mortality and satisfaction. As I mentioned, decanting the hospital bed capacity and freeing up that bed capacity for other patients, if that's something that is really needed, as it was certainly for some period of time last year. And reduced need for capital investment. Obviously, we're extending or expanding the available or the effective bed capacity of a hospital here without the expensive construction of hospital buildings. HSCRC staff is taking the lead on development of the report. We've spent some time with them, and they're clearly the agency of the two here who really has kind of the most dog in this fight. They've got to fit this model within the total cost of care model, and they want to really have answers to these questions on efficacy and the cost implications in order to go forward with something like this. We will be, attending the meetings on the report as it's developed. Those meetings will involve both agency staff and, of course, lots of industry folks and others who we want to, gain information from. And our role, I think, is our specific role too, in as far as putting this report together, is we want to, I think, develop a position paper to present. I think I'm thinking September would be a good time to do that, because that's when the report will be beginning to gel. And I think we just want to take a position on whether there is any role that's necessary or desirable for CON style regulation if this concept is launched in Maryland. And with that, I will stop on this one, and we can have any specific questions on this second innovation.
I have one. I think you may have covered it with the question whether CON is desirable. My one question I have about hospital at home is it's not a hospital at home. It's a collection of services that are currently provided in a hospital provided at home. And I'm not sure why we would need a large hospital system to provide services at home. And I wouldn't like to see this foreclosing the opportunity for other folks to come in and do it more efficiently. if those are home services. In other words, let's not lock up the home market on hospital-related services by putting it within the scope of CONs for hospital buildings would be a concern I have.
I think that's a very interesting observation.
I agree. I think that's a very important point. And I guess I wonder about the intersection, if you will, between the hospital at home model, the home healthcare model, and the joint venture hospice model, because it seems like these are all different variations of care provided in the home. Some at a high level, some at a medium level, and some at a low level, I guess you could describe it, and at different points in the life cycle. But it seems like it might be that as opposed to the hospital system being the ideal partner to provide the hospital at home, maybe it's the home healthcare agency that already has the home environment in place that expands the level of services that it provides, or the hospice agency that provides it. And maybe the way that one of the things that we should look at hospital at home is allowing joint ventures with existing hospitals and home care partners, and even think about EMS agencies as potentially those home care partners through community paramedicine models.
Dr. Pollack, I echo, because the patients, those who live in this community, they have home health care, they come to the hospital. They should look at the joint venture. That will be more feasible and more effective for the patient care.
Yeah.
Yeah, this Paul, Commissioner O'Connor, I know I haven't seen the type of patients they're talking about that would fit into this hospital at home model. But at what point does the cost of taking care of these patients at home exceed the more efficacious care and maybe quicker care in the hospital? Is that going to be part of the study, or?
Yeah, as I mentioned, there have been at least 2 formal demonstrations in the last 20 years with a number of hospital participants. And then more recently, and this may be a problem because maybe it's a little too recent for the research material to be developed, but more recently there has been this waiver program that I believe in April, we had 127 hospitals in the United States who were involved in this waiver for Medicare patients, and using this model under CMS guidelines. So I think I'm very interested to see what sort of research is brought together by HSCRC, and they are going to be using a consultant as well for some of this research and information development. I'm interested in seeing exactly what evidence we have on that question you asked. And obviously, I think intuitively, a key factor in success of this model is determining what are the patients, what are the appropriate patients where this could make sense, and not affect the efficaciousness, as you put it, of the different settings, but also where does it absolutely not make sense to try this at home, because it's so much more expensive than the hospital setting.
Yeah. Thank you.
All right.
Okay. If there's no further questions, we can go on to the last slide.
Yep. Ambulatory surgery facilities.
Yeah, and this is pretty simple. It's not programmatically driven necessarily, but I'm just updating you on a couple of things that have happened in the last year that certainly suggest that we're having some changes in our approach to regulated hospital services and unregulated services, and specifically we're talking about ambulatory surgery. So last fall, we got a certificate of need application, which we have reviewed and approved. And in this application, the University of Maryland Medical Center Midtown was seeking to establish an ambulatory surgical facility, not to add operating rooms at the hospital, but to establish a distinctly licensed ambulatory surgical facility with 3 operating rooms that would operate outside of HSCRC regulation. The HSCRC obviously did determine that the project was well situated to function separately from the hospital surgical facilities. It is kind of concerned about making sure that we do have separate, truly separate facilities. And with the representations from the applicant on how that facility would operate, they basically determined that it could operate as an unregulated facility. And at least to my knowledge, that was the first time we ever saw this happening in an actual hospital building. The building in question is on the campus of the Midtown Hospital. It is across a public right-of-way. So there is a street. It's connected with a skyway, but it is a hospital building, and it's falls under the hospital license. So this was allowing an unregulated healthcare facility to be created within a hospital building. And more recently, just last month, we got a determination of coverage request. Now, this wasn't a certificate of need because the number of operating rooms involved was lower. So it didn't meet the threshold for requiring a certificate of need, but it did come in as a determination of coverage request, which is a standard part of reviewing any surgical facility that's being developed, because we do have this threshold between what's regulated under CON and what isn't regulated. And this one came in from a hospital that is taking an existing part of the hospital that has been developed as a dedicated outpatient surgical center and physically reconfiguring that extensively so that the operating rooms in that center are being divided. 2 will be located in what is proposed as a distinctly licensed ambulatory surgical facility. And the rest of the operating rooms will all but one of the other operating rooms will remain as part of the Berman Center, which again is a dedicated area of the hospital for outpatient surgery. So this is a much more tighter kind of integration within the hospital itself when we compare it with last year's Midtown project. And this one, we have not gotten a determination from HSCRC. They are aware of our determination that this passed muster as far as something that could go forward and seek licensure. We didn't need a determination as part of our review process because, again, it wasn't a certificate of need application. It was just a determination of coverage. But we've taken that position, and I think these positions that we've taken, approving the CON and also issuing the positive determination of coverage, positive in the sense that a CON would not be required, they both align with the policy that we've pursued in regulating surgery, which is that we do like to promote the use of the lower cost, unregulated settings for outpatient surgery whenever possible. So that concludes my description of what's going on in that area. I'd be happy to answer any questions commissioners have.
I have one. Do we have any concern that if you're putting them in the same space, that the hospital would be able to, shift the costs back and forth between the ASC and the hospital in a way that could game the system with the budget cap? And I haven't thought through exactly how one would do that, but I'm not an accountant either.
And that is clearly, I think, what HSCRC is going to have to incorporate into their decision on whether this is something that they can live with under their model of payment model. There have been discussions. So contemporaneous with our review of this this project for a determination of coverage, Howard County General staff. We're meeting with HSCRC staff as well to talk to them about this. So, but that is, I think, going to be a central issue, and it's directly an issue for HSCRC.
Mhm.
I think this is going to be, if this gets approved by HSCRC, I think the floodgates will open on that. You're going to see a lot of that.
Well, perhaps. I'm not sure. I think that all boils down to specific regions and the markets, and the physicians who've established a lot of true freestanding outpatient centers. I think as a business strategy, this certainly is something that is nice for hospitals to have, something they can go to in terms of trying to hold on to market share in outpatient surgery in their markets. But the conditions in different markets, they vary from market to market. So it will be interesting to see just how much uptake there is of this if HSCRC allows it to go forward.
So previously, there were two things that drove cases, or actually three things that drove cases into the ambulatory surgery facilities. One was availability of operating room time. Two was convenience. So if you own your own ASC and you control the environment in the room and in the ASC, that's generally nicer. You can control the environment for the patients as well. And third was the potential for profitability on the outpatient side of the equation on the part of the surgeon who owned the ASC. On the part of the hospital, their hospital system, you essentially lost revenue anytime you move a case to an ambulatory surgery facility, because theoretically, you're only going to get 1/3 of the revenue that you had when the case was done in the hospital, and you would theoretically, at least over time and market share shifts, lose 50% of the revenue that you had when you did the case in the hospital under the GBR model. So you're replacing, you essentially lose revenue by making the move if you're a hospital system. EQIP changes all of that, right? Because there's no longer potentially a loss. There's a potential real gain for everybody by moving to the lower cost facility when everybody is aligned with regard to the total cost of care model. And many cases that are currently being done in ambulatory surgical facilities are cases that are where there's a grouper or a bundle for an episode, I guess would be the way to refer to it. There's an episode listed that you could potentially benefit from in the EQIP model. So that'll be very interesting to see how this changes the environment, because it really aligns incentives in this model dramatically differently than we've seen previously. And this model, putting the ASFs within the general hospitals, will become very attractive to hospitals in the context of that market reality.
Well, if there are no additional questions, that concludes our presentation.
Thank you. On to agenda item number 11, overview of upcoming activities.
Thank you, Dr. Pollack. I don't have a full list for July. I would note that we would expect at least one CON. Our authority under advanced directives, we do have an application from Advault to continue their certification to work with CRISP to share information on through their standalone electronic advanced directive tool. We will be working towards, but can't commit to yet, the release of another set of data for our where the cost episode reporting. This will be a fairly significant expansion. We are resolving some final technical issues, but would hope to share it with the commissioners in July. If we're not able to do that, we would still proceed with the release of that data in early August when it becomes available, and then present to the commission at the next commission meeting, which would be in September. I expect that we will add additional items. Typically, the July meeting is a busy meeting because of the fact that we don't have a August meeting. So I'll update you on that over the next week as I have a clearer idea on what's happening. I did want to also note two things. One, the intent on this last agenda item was to these would be items that perhaps the commission staff would deal with independently and at some point inform the commissioners. The intent here is to get your input at an early stage and your thoughts as innovation tied to the total cost of care model becomes a more widespread priority, not just the job of HSCRC. And also to signal to the industry that we want to use the scope of our regulatory authority to align that to the extent possible. Obviously, we can't violate the law, but we want to stretch our authority to the extent we can to consider innovations. And the intent here, this is a public meeting, although I only see 4 friends sitting here here in the building, that people should be thinking creatively and coming to us with ideas. We can't, as staff, commit to any approval, but we do want to signal that we are open for innovations. So that's an important walk-away point for all of us to think about. And as we move forward through the model, work to engage commissioners as well directly in working with colleagues across the state in these activities. Lastly, I just wanted to note, Dr. Thomas will be with us only for a few more months, but staff has been working with him on his initiatives, and I didn't, if he's still here, inquire if he had any update on his vaccine initiatives through barbershops or any funding that he's been able to garner for his initiative. I am aware because I talked to him and he cut me off and left me hanging when MSNBC called to talk to him. I couldn't understand that, but perhaps he can explain why he would have treated me so rudely. But anyway, Dr. Thomas, are you there? I think he may have dropped off, but he has been making progress with several organizations in the healthcare community. I don't want to steal his thunder on that, but he's also got quite a bit of visibility at the national level, and clearly new ideas in terms of vaccine outreach to hard to reach communities is something we all have to continue to think about. So thank you, Dr. Pollack, and thank you all of the commissioners for your engagement over the last 2.5 hours.
Thank you, Ben, and congrats again to everybody for getting through a ginormous agenda in 2.5 hours, less than 3 hours. If there are no further comments, concerns, or questions, I will entertain a motion to adjourn.
So move.
Second.
Any opposed?
You all.
Thanks, everyone. Enjoy
Thank you.
Enjoy the month.
Bye-bye.
Bye.